that will give time for those. So just to welcome everybody, this is day 2 of the Future Pandemics workshop. Yesterday we had several sessions on the emergence of new diseases, and today we're really thinking about tackling new diseases and what we can learn from past epidemics for, lessons for the future to help us prepare. We have 3 speakers, Salim Abdool Karim, Ted Cohen and Jess Metcalf, and we're going to start with Salim Abdool Karim, who's Professor of Global Health at Columbia University, has many roles, but is also particularly Director of CAPRISA, which is the AIDS Research Centre in South Africa, or based in South Africa. So perhaps, Salim, I can hand over to you.
Thank you very much. It's indeed a pleasure and an honor to be here and to share with you just some perspectives from working in Africa about what we've been grappling with in terms of on-the-ground issues, in terms of looking at these epidemics and figuring out what to do. So I'm very pleased to be able to present to you a perspective on some of the interventions in tackling new diseases and what are some of the issues we're grappling with. I would like to thank the organizers for inviting me, and I think as I go through this, I think I'd like you to get a sense of perspective of the nexus between science and public health. So in looking at what I'd like to sort of touch on is I want to sort of learn from the past so that we can look at what have we benefited from those experiences to better prepare for the future pandemics. And I draw specifically on our experiences in the Ebola epidemic, the HIV epidemic, and most recently, COVID-19. I'll draw on those lessons and pick out what are some of the key issues and how have we looked at interventions? And then I'll end up with touching on some of the challenges that we're facing in planning the way in which we deal with these epidemics. So let's start off with just by way of background. Africa has been in the midst of several epidemics, and almost every country in sub-Saharan Africa has been grappling with some form of epidemic in the last few years. If you just take the period since 2016, we've been grappling with and trying to deal with epidemics across the board. And specifically, if I now want to focus on the Ebola epidemic, we had an outbreak in 2014 that lasted about 2.5 years, where we had about 28,000 cases and over 11,000 deaths. And indeed, that outbreak was a wake-up call. It was a wake-up call because of the tardiness of the response. And to some extent, the global community was caught flat-footed. Within Africa, we had really very little capacity to respond. And it highlighted the challenges that we were facing in Africa. And indeed, one of the things it led to was the creation of the African CDC. And I recall very clearly, making the arguments and listening to the way in which the African Union plenary heads of states was trying to understand how would this work, what would its values be, and how would it work across the continent as opposed to within countries. And I'm very pleased that we have such a facility because it has proven to be invaluable in the COVID-19 response. And even though we've dealt with that outbreak and we had its challenges, we're now dealing with another outbreak. This one's a bit smaller in the DRC, just about 100 cases so far, but it's still ongoing. We have not yet been able to contain the current outbreak. If I look at some of the key lessons, besides what we've learned about establishing local capacity, I think the early identification and decisive action was critical. The fact that when the first cases were found, reporting was a challenge, and then declaring it as a global problem that we needed to contain, before cases started spreading to the US. I think we saw the importance of early identification. The second was the importance of health worker protection, because that proved to be a major concern. Because of the nature of the way Ebola spreads and the high risk that health workers have, the importance of PPE, protective equipment, the cleaning, sterilization. And I've given you some idea of the particular challenges that Ebola presents in the picture on the right-hand side. And then we found that as we were tackling the challenge on the ground, and the South African team was in Sierra Leone, trying to set up, and our country established BSL-3 laboratory to do the diagnostics. The public health measures based on diagnostics is to deal with it at a community level, to identify the contacts and to do the tracing and to do the diagnostics on those. But we had real challenges because of the stigma that was associated with this. And they sort of knew that when the Ebola teams were coming around, they would all sort of disappear because they were concerned that they would then be taken and put into a quarantine facility. And so we learned the importance of explaining and engaging with people about how they would like us to do some of this contact tracing. And then finally, a comprehensive approach to outbreak control. That, we initially, the emphasis was on one thing or another, but we realized we actually had to do several things in order to deal with this problem. We couldn't just, focus on one or two issues. We had to take a much more comprehensive approach. If we look at the HIV epidemic, of course, a much bigger problem with close on to 26 million people living with HIV in Africa and nearly 500,000 deaths. We have nearly 1 million new infections with HIV each year in Africa. So it's giving you just some idea of the scale of the HIV problem. And within sub-Saharan Africa, young women and adolescent girls really account for a major part of the epidemic and have the highest rates of HIV. So we have quite a unique set of challenges in dealing with HIV in Africa. And we've learned many lessons. I think among the many lessons we learned was the importance of testing, because testing was an entry point into prevention or into treatment. And having a rapid, cheap, reliable diagnostic test that told you whether you're HIV positive within minutes really was a game changer. Until then, we were busy sending things to the lab, taking time, we lose results, and it just posed so many challenges. And so rapid point-of-care diagnostic made a big difference. The second was the human rights approach. And I think here we owe much to Jonathan Mann, who really put forward the concept that we needed to see it as not in conflict, but to see it as part and parcel of the solution. And as we dealt with the many vulnerable groups, we realized its importance, together with community mobilization and advocacy. In fact, the advocates from the AIDS conference in 2000 in Durban led the charge in terms of making treatments available. And then finally, we saw for the first time, unique new mechanisms, whether they were bilateral or whether they were multilateral, like the Global Fund, where many countries, rich countries, were contributing in order to enable poor countries to afford making treatment available. So I think there were all of these important steps that were taken that lay a fertile ground for preparing better for future epidemics. Now I'll deal with COVID-19, which in Africa we have seen just over 1 million cases and about 23,000 deaths. But as we all are painfully aware that this is probably a gross undercount, not just because of the numbers of asymptomatic infections or mildly symptomatic infections, but also the challenges in establishing and scaling up testing in many countries in Africa. In COVID-19, the way our world has changed has been perhaps the most striking of the features. Let me walk you through this month by month and give you a perspective of how much Africa has been impacted. In fact, the whole world has been impacted. So on the 1st of March, the countries shaded in blue are those countries that were just continuing their normal activities. The countries shaded in yellow had some recommended restrictions, but they were not obligatory, and they could be ignored if needed. And then we look at the light orange, which are countries that had some mandatory restrictions. And then the very dark orange are those that were in lockdowns. They had very substantial restrictions. So when one looks at the 1st of March, you can see that China and Italy and a few other countries have quite substantial restrictions. India just introduced some restrictions, the whole of Africa, much of the Americas and Europe and Asia had no restrictions. A month later, the world has changed. 1st of April, 86 countries on either national or subnational lockdown. Many countries in Africa, much of Europe is on restrictions. Russia, China, India, all are in restrictions. Australia just introduced some optional restrictions, New Zealand under lockdown. A month later, on the 1st of May, the world has changed again. We see a situation where more of Africa now is in restrictions. China is easing its restrictions. Russia and India are under lockdown. Both Australia and New Zealand now are in restrictions. We look at the 1st of June, the world has changed again. Most of Southern Africa have eased their restrictions. China is back under lockdown. Australia and New Zealand now have contained the epidemic, and we're seeing South America feature very strongly now in terms of restrictions. If we look at the 1st of July, the situation is changing yet again. More emphasis again, controls in India, China, and in South America. If we look at the 1st of August, the epidemic is again evolving. Australia is back under lockdown. If we look at the 1st of September, we can see that South America is facing a huge challenge. India continues to have a growth of the epidemic, and Africa is now easing its restrictions across the board. So I think, I wanted to give you a sense of just the way in which, in rapid fire, our whole world was rapidly changing, and across many countries. And in each country, sometimes we get very self-absorbed in dealing with the challenges in our own setting, not realizing actually many other parts of the world are also in turmoil, trying to grapple with our rapidly changing environment. Within South Africa, we had our first case on the 5th of March, and because of very early interventions, we averted an epidemic that would have looked very much like the UK epidemic. In fact, for the first 3 weeks, the epidemic was growing in South Africa at the same rate as the UK. But because of very early interventions with restrictions, with an early lockdown, we averted the initial peak. But we didn't avert the peak because if we still had it, we just had it about 8 weeks later. And as we hit the peak and quickly overcame it, because by then we had instituted many of the public health measures, we saw a much lower peak and a shorter peak than we would have expected. And now we are back to having released most of our restrictions. So as we look at how this epidemic has really challenged us on the ground, what have we learned? What have been some of the key issues for interventions? Well, I'll just draw on a few. And the first is what I'm going to talk about is about the importance of early action, early identification, early appreciation of the challenge, and early action. And so I'll start with at the global level. In fact, listening to Eddie yesterday and how he was describing when he received the ProMed alert, I was just reflecting on the fact that when I got the ProMed alert, I was actually on vacation in the mountains. And this thing comes through about the cases of pneumonia in Wuhan. and at that time, I didn't think much of it. I said, this is just SARS, probably, you know, they'll deal with it, not realizing how things would change. But I realized barely 2 weeks later, around the second week of January, when the sequences became available, and my colleague comes to me with this Twitter saying, here's the sequence on Twitter. I said, you can put a sequence on Twitter? He says, yeah, this is how, you know, the world is changing. We're getting information in a very different way. And then shortly thereafter, the WHO took its leadership mantle, declared the global health emergency, declared it as a pandemic a short while later, and really set the stage for the way in which we reacted. At a global leadership level, I mean, I have seen WHO really rise to the occasion in so many ways. And the thing that I have felt perhaps was a shortcoming is that, you know, the United Nations as a whole, across all of the sectors, we've had these high-level meetings for HIV, for TB, for non-communicable diseases. In fact, I've put the declarations that emerged from each of those high-level meetings. And the picture you see there is from the HIV high-level meeting in the United Nations in New York. I would have thought that, you know, the UN would have done something similar, if not have it physically, but at least have it virtually, so that we can get guidance across multiple sectors and not just the World Health Organization. I felt that that perhaps was a missing piece in the way in which we've responded to COVID. If I look at the importance of early identification and action at a country level, that has been critical. I actually pointed out earlier the way in which the epidemic changed in South Africa. So if you look at the initial period, I'm indicating it with my pointer, South Africa's epidemic was growing, you know, like most of the others. And then when the lockdown was instituted, you can see how it changed and how the epidemic slowed. And it's reflected in the doubling time. Before the lockdown, the epidemic was doubling every 2 days. And thereafter, it slowed community transmission down to a doubling of around 15 days. And we always knew that, you know, those kinds of substantial restrictions were really not sustainable for long periods. And so as we eased those restrictions, the epidemic slowly started taking off again, because we were just never able to contain it, given the complexity of trying to do that in a South African setting. And so that need for early action enabled us to prepare. So by the time we actually had our surge, we had already built field hospitals with oxygen. You know, if you take just in Cape Town, the Cape Town Convention Center, within 6 weeks was an 800-bed hospital with about 17 ICU beds, and every one of those 800 had an oxygen supply. Just giving you some idea of the importance of preparing and being ready. So when the surge came, we actually didn't even use all 800 beds. I think at most we had just over 400 patients admitted to the Cape Town ICC. So I think it's that preparation that was quite important in maintaining a lower mortality rate than we would have otherwise expected. So I talked so far about the importance of governance and about governance at global level and governance in terms of at the country level and early identification, early action. We also learned from past epidemics that you have to figure out a way to avoid denial, interference, and divisions, because those are plentiful. In a situation of stress, there'll always be those individuals and those groups who want to do it differently, who know better. And you know, it is no different in Africa. Within South Africa, of course, there are groups that, you know, are arguing this is no worse than influenza. Why are we even bothering to do anything to slow this viral spread? We had individuals that said we should just, you know, aim for herd immunity. We've had them all in our country. And of course, we look, you know, almost jaw-dropping the way in which the US has been dealing with this at a political level. You know, the level of denial initially, and then, you know, obtuseness and obstruction thereafter has been quite striking. Now, watching that, of course, brings us to our own situation, because in South Africa, we've had this before. We know what this can do. Denialism compromised our own South African HIV response. And this affliction, we've been watching how it's impacting several countries in COVID-19. And, you know, we had a president, Mr. Mbeki, who just didn't believe HIV even existed or that it even caused AIDS. And trying to grapple with that kind of, you know, political challenge when you need everybody rallying around and you need common purpose against an enemy like HIV really put us on the back foot. And, you know, there are many estimates that hundreds of thousands have died as a result of this political decision. And the third point I want to make, so the first is about the importance of early identification, action, leadership. The second is about the importance of avoiding, you know, divisions and political interference. The third is the importance of science and making information rapidly available. And I was describing how, you know, I first saw the sequence on Twitter. I don't even do Twitter, so to me it was just amazing to see how, you know, new forms of technologies and the younger generation have been using that so effectively. But down to our traditional modes of publications have all been turned on their heads. We are now quoting articles before they've ever been peer-reviewed. We're seeing turnaround time from journals that, you know, would have been unheard of before. I mean, PubMed shows that from January this year, 52,000 articles on COVID-19. And if you add the preprints, we're up to over 60,000 articles. That's over 10,000 articles, around 10,000 articles per month. Just give you some idea of just the explosion of information and the way important and the important role of science. Because in order for us to advise governments, as I have to do in South Africa, we need that information readily available and quickly available. So I wanted to just share those three key lessons about leadership, about ensuring that you have political support and not political obstruction, and the importance of scientific evidence. Let's go to some of the intervention choices that scientific evidence made available to us. So when we look at in the COVID-19 prevention toolbox, as we've tackled it in South Africa, we've looked at it and put together evidence and we tried to act. So for example, in South Africa, we recommended to the government that we should start wearing masks. And this was about 3 weeks or so before the WHO recommended mask wearing. And we were very pleased to see the government adopting that, and very quickly became the standard that across the board. And being able to use information in that kind of way to effectively convince the policymakers and to get policy implemented very rapidly was really one of the key things that we saw occur in COVID-19, as opposed to a situation in HIV, where initially, we had very few tools, and it took a long time to build this toolbox, trials upon trials and decades of research. It just illustrated to me how a COVID toolbox with evidence can be generated within a matter of 6 months compared to what we've been doing in HIV. Of course, there are many differences, but I mean, for me, it was just the illustration that the prevention toolboxes took such a different, and they went a different route. But importantly, that both sets of intervention choices have sound scientific evidence that underpin them. And they've got the way in which they're being implemented and the way in which WHO has been providing the evidence to guide all of us has been really central in developing those toolboxes. And we've also realized that, we've got to tackle this problem. Initially, we were all sort of frantic, helter-skelter trying to deal with this epidemic because of the speed with which it grows. But we quickly realized, actually, we can't be preparing for just a sprint. We've got to be planning for a marathon. This virus is going to be with us for a little while. Okay, we're all putting our sort of money on betting on the fact that we're going to get a vaccine. But even if we have a vaccine, it's going to take a long while before we have enough doses to create levels of immunity that would be meaningful. And as we look at the way in which the 4 stages that we've been grappling with, the first is the epidemic itself, and the virus is spreading, and we're trying to flatten the curve. And then we're trying to get to a point where we've either got containment, or in the case in most countries where you've just got low levels of transmission. And then we've got to try and figure out a way to coexist with this virus, where we can sort of get on with our lives and our economies and open our schools and so on, and figure out a way to do that, and to do that safely, until we get to a point where the virus is no longer a threat. And so this level of planning has meant we've had to change gear. We've had to rethink, and importantly, we've had to look at our response as one that changes systematically over time, because the epidemic is changing. You cannot, what you were doing, you know, when you had 10,000 cases is not what you can be doing, all of it, when you are 100,000 cases. Your response has to change organically in response to the changing context and the changing epidemiology. And so one of the things I'll touch on is the way in which we've had to change from anxiety to self-efficacy, and the way in which we had to pivot the prevention paradigm in South Africa, and how that has been really key to much of the way in which we've been doing this in Africa, and to enable this new normal to occur while mitigating the risk of a resurgence. So let me illustrate this as just using one example of how we've had to adapt our interventions and to deal with the issues in those interventions. So in South Africa, we went the route of initially, very early on, government action. We sort of worked on the premise that if we went our traditional public health route, where we investigated, we understood the modes of transmission, and then we developed our prevention strategy, we identified our key messages, we would implement that on a pilot scheme, adapted with community involvement, and then we would look to scale it up initially with the early adopters. That will take us a few years. And so our traditional public health paradigm just wouldn't work here. And so we thought the better way to go was to just go for initial government action. And that government action was to institute quite substantial restrictions upfront, stay-at-home orders. And that created quite a lot of anxiety. Why was the government doing this? This must be really scary. And then on television, to see what's going on in Italy and to see what is just starting to go on in New York really set people up in a state of, anxiousness that, how do we deal with this? But then we had to change that. We had to take people from that state of anxiety and we had to pivot. We had to enable them to feel that they could control their own risk of the coronavirus. And trying to do that so that they were empowered and they felt empowered, and so they could take individual action. And in maintaining their social distance with others, in ensuring that they minimize their movement, wore a mask. And so that switch from initial government action, switching it and pivoting all the way to individual action, that each person takes responsibility. And then we had to pivot it or extend that pivot into the point that we've been focusing on, which is to achieve collective community action. And in South Africa, that's, our society is built on this principle of Ubuntu, where, it fundamentally means, I am because you are. It's the fundamental understanding of our context, of that we exist not as individuals in isolation, but we exist in the context of our community. And so in COVID-19, it's about, I am safe when you are safe. You are safe when I am safe. So I take precautions, not just for me, but also for our collective good. And I think that shifting paradigm for prevention has taught us so many lessons. And, we made many mistakes in doing all of this. But I think fundamentally, trying to do the shift was central to the way in which we responded. And that had to be done in the context of what we were grappling with. So let me end off with just 5 key lessons that I'll draw on with some examples. And this is a collective wisdom of, perhaps the most important things we learned from our history of dealing with many epidemics in Africa. Well, the first is our global interdependence. That at a global level, our epidemic in South Africa and much of Africa actually comes from Europe. Interestingly, we actually have very few viruses circulating that are from the original strain in China. Most of what we're dealing with comes from the Europe, and that's just historical. We have so many links with Europe, and so we are globally interdependent. But then when we were trying to grapple with this challenge, we couldn't do so in isolation. We had to work with our neighbors as a region, and the Africa CDC, and I serve on its coronavirus task force, had to take leadership to assist countries that were less prepared, and to ensure that we worked well as a region to try and draw lessons from each other, support each other, and most importantly, assist each other in ways that ensure that we were not trying to contain this on our own, but we were trying to contain it all together. And then at a country level, to get country leadership, to get people to buy into the common purpose. And I mean, it's been really important in Africa to see the role of the Africa CDC and the AU itself, the African Union, putting its muscle behind and its support behind the African CDC, not just in words and spirit, but also in financial terms. The second is community involvement and the way in which we have valued our collectivism. And, we saw, I gave you examples from Ebola and from HIV, and COVID, it was no different. To give you one example of how that was implemented, the South African government had initially established very early in the epidemic a ministerial advisory committee on COVID, which I chair. And as we were pivoting our response, we realized that we were ill prepared as a group of medical and public health practitioners to really be the driving force behind that pivot. And so the government established a different ministerial advisory committee, bringing together civil society, people with understanding of behavior change, of social change. And that committee now is one of the main advisors to government about how to respond, not just the medical people like myself. And then working together for early identification. And here, at the beginning, I think we were, of the 55 states in the AU, I think it was only about 11 states could actually had the capacity to do COVID testing. But within a matter of weeks, with the Africa CDC's assistance, with WHO assistance, every country in Africa now has the PCR platform to undertake testing. And unfortunately, testing requires foreign currency, and that has been a major concern in many countries. But the African CDC created a platform to buy in bulk so that we would get better prices rather than individual countries trying to negotiate prices with individual suppliers of kits. And so we saw how working together helped all of us in Africa. I don't want to make it sound romantic because it's anything but. All of this working together comes with a lot of politics, a lot of people pulling in different directions, and a lot of things that, we take, one step backwards before we take 2 steps forwards. And then I'll touch briefly on the importance of evidence-based policy and decision-making. And here, not to go the route of, just banking on herd immunity and waiting for a vaccine to come, but taking a comprehensive approach, taking an approach that says, let's do all the things we can to minimize the spread of this disease. And then finally, building on what we've seen in HIV with the creation of the Global Fund, UNITAID, PEPFAR, in the situation of COVID, we've seen how COVAX was created by Sept, Gavi, and the WHO. COVAX is put very simply, is a mechanism where countries that are very poor can come together, and Gavi will raise funds to enable them to buy vaccines. And other countries like South Africa that are not Gavi eligible, we can pool our resources into that pot. And so the idea being that COVAX will secure vaccines, COVID vaccines, for 20% of the populations of all of the countries and distribute it equitably, and really challenge this notion of vaccine nationalism that, you know, we're seeing so prevalent in the US and other countries that, you know, are just buying up millions of doses, just failing to understand that there's a very fundamental issue in this epidemic, that no country is an island that can be protected just by itself, that all of us are interdependent, and that their ability to control coronavirus, the COVID-19, is dependent on all of us. And so the importance of seeing this and creating mechanisms to give concrete expression to global solidarity, to those who can afford, assisting those who can't, so that we can all come out of this and deal with this as a global community. I hope I've given you a sense of how much we have learned from our experiences, Ebola, in HIV, and now in COVID, in order to be better prepared to take on the next epidemic. Thank you.
Thank you very much indeed, Salim. That was absolutely excellent. We can take a couple of quick questions now. You can either ask your questions in Slido, or if you don't mind being recorded, you can put your hands up in the chat, and then I can ask you to give your question. We have a question from Chris Dye. Chris, would you like to ask your own question?
Yeah, thanks very much, Valerie, and thanks, Salim. That was really a superb overview. Absolutely what we were hoping for. Thank you for that. As you were speaking, I think I wrote down about 10 questions. So let me just try one general question on you,
Sure.
which is up on your point about interdependence. What we have seen in the COVID epidemic is a remarkable amount of interdependence and collaboration among the scientific community, which has led to those thousands and thousands of papers that you talked about, and really a very open and rapid collaboration around the world. Some have argued that it should have been even quicker, actually, as Eddie did yesterday, in fact, you'll remember, but it's been good. On the other hand, the political interdependence and collaboration has been awful. And therefore, your presentation of what's happening in Africa sounds like it's, well, let's say, a rather favorable view of what's going on. And specifically, I wanted to ask you about CDC, the Africa CDC, and I know you're involved with them, but, and I recall after the Ebola outbreak in West Africa, how CDC came into being. So just frankly, how well are CDC doing in coordinating the response to COVID across Africa, just as one example of the really quite vexed question of political interdependence?
Yeah, I think for an organization, you know, at such an early stage of its development, you know, it's barely a few years old, to be put into this kind of situation has been quite striking. And it has really challenged their system, because I have to start off by saying, I think the organization, you know, hasn't really bedded itself down and doesn't have, you know, enormous capacity. And they were just fortunate that in preparation for COVID, very early on this year, that a company called McKinsey was available and provided them with some support and helped them build their systems. And then the MasterCard Foundation came in and funded that kind of support. So building that kind of infrastructure was central. And the organization has been very effective for that reason, that it has an institutional capability. It has people with skills. It has people who have know-how and know how to work at country level as well. But what it has been really enabled it to really act is the fact that the African Union leadership, the heads of state, have really been the driving force. You take, for example, the African Union has created the consortium of COVID vaccine trial sites, endorsed by the AU. You know, there's already 17 sites that are part of it. Drug companies are already talking about using this infrastructure to do COVID vaccines. I'm just using that as an example of how there will be vaccine trials, we hope, over the next few weeks across many countries in Africa, as opposed to just the 5 trials that are currently underway. So I think that's what we have seen. But that has come at a cost. And that cost has been that the organization has really not been able to focus on anything else. It has diverted its energies and its focus to COVID. And in doing so, and having external support, we haven't yet built enough internal capacity and internal systems to be rock solid. But what we've done is just built the starting, I call it, you know, we're crawling, not yet even walking or running. But while we're crawling, you know, we're getting somewhere at least. So I don't want to make it sound like it's, you know, all easy going. It has its challenges, but at least there's progress. I hope that was helpful, Chris.
Thank you.
Thank you very much indeed. I think in the interest of keeping to the timescale, we'll go on to our next speaker and hold Chris's other 9 questions, or however many there were on the long list, over, and hope to pick up 1 or 2 in the discussion perhaps. But perhaps I could now thank Salim very much again